So that's really good. Let's move on to hips now, because hips obviously is another aspect, a big aspect of your work, and I know in particular that you offer some hips or hip replacement surgery that is quite unique to some extent, and maybe a lot of surgeons that don't offer this particular anterior approach that you offer. Would you like to just outline that for us?
Yeah, sure. So hip replacement surgery, the hip is a ball and socket joint. We talked about this before. The actual biomechanics are relatively straightforward. The traditional way to put a hip replacement into the hip joint involves a scar on the side of the thigh running into the buttock area. And through that scar, the surgeon can enter into the hip joint, either skirting over the front of the upper thigh bone or to the back of the upper thigh bone. And that technique works very well. Okay, this is a technique that I was trained to do with this sort of surgery. And I have to admit, up until 9 years ago, I was very happy to be doing standard hip replacement surgery with a standard, what we call the approach, the surgical dissection. My preference was to use something called the posterior approach. And I was very pleased to see how my patients responded to that sort of surgery. And by what I mean is I would do a hip replacement on a patient. The next day they would be sitting out of bed. The day after that, they would be walking with a Zimmer frame or crutches, pain control with appropriate painkillers. By day 3, moving on to sticks or crutches and ready to be discharged from hospital. And then I was offered the opportunity to go to the continent, actually to Belgium, to see a surgeon doing hip replacement surgery through a different technique. And I have to be honest, I was a bit skeptical. I'd been a consultant for several years. I felt as if I knew what worked and what worked for me. And like a lot of surgeons, I felt that if I was going to consider changing what I did, it would have to be something fairly significant in terms of difference to my patient that would justify me wanting to change. Yeah. So I went to Belgium to see the surgeon operate, and he was using this anterior approach, a cut at the front of the groin. And the real benefit from this technique is, rather than cutting through the skin and then splitting open the buttock muscle, the gluteus maximus muscle, and then detaching muscles or tendons from the side of the thigh bone in order to get into the joint, this technique, after you cut through the skin, there is no muscle damage. Instead, we just sweep or move muscle tissue out of the way. It allows us to get down to the hip joint without damaging muscles and tendons. The actual operation itself is the same surgery, putting a new artificial socket, inserting a new artificial ball attached to a metal rod that goes down the inside of the thigh bone. At the end of the operation, once this new ball and socket is in place, these muscles just flop back into position without any sign of damage. And the stitching up is literally just, a few stitches in the fascial layers and then some stitches to the skin. So that was quite a surprise to me to see this sort of surgery. Technically, it looked a bit more challenging. And actually, during the surgery, I was thinking, well, am I going to want to change what I do to learn this technique? At the end of the day, we went up to the ward to see the first patient. And for me, what I was expecting was a patient lying in bed with a drip, with an oxygen mask on, maybe in a bit of discomfort, but not in agony. But this was the typical scenario at the end of that day, having had a surgery at 8 in the morning. Yeah. The patient was walking down the corridor. Right. The patient was walking down the corridor with just one stick for balance, not even really using the stick very much. And that was my jaw-dropping moment. At this point, I thought, well, I need to maybe look into this a little bit more closely and decide why this is different to what I see. Yeah. And that's how my journey started. And to the point where now my routine practice, unless it's not feasible, is to use anterior approach hip replacement. And it comes down to basic principles. What would I want to offer my patient from a hip replacement? What would my patient want to achieve from a hip replacement? Well, it seems sensible that they would want to have a relatively safe operation, good positioning of the implants, which means it's going to last well long term, no muscle damage, so that they don't have so much pain after surgery, because damaged muscles hurt.
Yeah.
So less pain after surgery, therefore quicker mobilization after surgery, and potentially, because these muscles aren't damaged, potentially less risk of dislocation, although that's contentious. But logic would say that if those muscles are back in position and working normally, the risk of the ball popping out of the socket may well be reduced as well. And some people are pleased that the scar is shorter. Personally, I'm not worried about the length of the scar, but my patients would be pleased with a good cosmetic appearance where it's feasible. So this technique, we can use a scar in the groin, which is even what we call a bikini incision. So it's in the lines of the skin crease, so you can almost not, you can't see the scar after maybe a few months. It really is a very cosmetic option.
How long would you say it takes? So, you mentioned that the patients that you saw, then they were up and they were walking along the corridor that day, the end of that day, having had the surgery. How long would that normally take for the patient is having the standard posterior approach to get to that point?
To get to that stage, I would say on average, it would be about 2 or 3 days.
Yeah.
So I mean, if I look at our length of stay data for the Royal Free Hospital NHS Trust, multiple surgeons, I'm the only one that does anterior approach surgery, but for the whole department, I think the average length of stay after routine hip replacement surgery is something like 3.5 to 4 days.
Right.
And don't get me wrong, some of my patients will stay longer even with anterior approach surgery, but my feeling is that the majority of patients are actually, from an orthopedic point of view, fit for discharge the day after surgery.
Right.
And there are numerous units around the world who are offering same-day hip replacement surgery, in and out in the same day. And a lot of those units are using anterior approach as part of that system.
And just to sort of clarify what we mean by in terms of the muscle cutting that you described. So again, correct me if I'm wrong here, but imagine my fingers are the fibers of that sort of gluteal muscle at the back. With the traditional approach, we're kind of cutting across, so we're kind of splitting the muscle like that. Is that correct?
So the gluteal muscles, if you imagine these are all the fibers of the muscles, then you actually split the muscle open like this.
Okay.
So they're in the line of the fibers, but there is still a big rent in that massive buttock muscle, the gluteus maximus muscle, to allow you to get to the level of the side of the thigh bone, what we call the greater trochanter. And at that point, deciding either to go over the front of that bone or behind that bone to get into the hip joint. In one route, you have to damage and cut open and detach the gluteus medius muscle, and the other way, underneath the bone, you have to detach a couple of tendons, the piriformis and the obturator tendons from the underside of the thigh bone, and all those structures need to be stitched back into place. And what people don't talk about is, especially with the route over the top, what we call the anterolateral approach or the hard hinge approach, damaging the gluteus medius muscle and then trying to stitch it back together. There is a percentage of failures of that muscle repair. And when that muscle doesn't repair well, then patients will permanently limp after surgery. You don't see that problem with anterior approach surgery because, as I said, the muscles are just swept away. There's no damage to the muscle fibers. You go between muscle groups. It's what we call an internervous intermuscular plane, the route into the hip joint without damaging muscles, without denervating muscles, and therefore at the end of the surgery those muscles just flop back into place.
That's excellent, amazing. And you say the glute medius is a very important muscle for the hip, isn't it? So it's
well, I've seen over my 15 years as a consultant, a few patients who have been left significantly worse off by hip replacement surgery because their anterolateral hard hinge approach has resulted in failure of the muscle repair, and they're left with a permanent limp. And that awful lurching, what we call a Trendelenburg gait, after what looks otherwise to be a successful hip replacement, that's a significant major downside for the patient.